irritability, and suicidality. Somebody else repeat.
This is for bipolar 1, right?
With the main. So, sleep is very important with bipolar disorder. With a patient with bipolar disorder, what we instruct them to do is that you really shouldn't work shift rotation. You should be on a consistent sleep-wake cycle. It shouldn't probably work the night shift. You should contact the healthcare provider if you miss even 1 hour of sleep. So if normally you sleep 7 hours of sleep a night, and a person with bipolar disorder finds themselves only sleeping 6 hours, why do you think they should contact the healthcare provider? Yes.
You might be going into mania.
Excellent, 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 fantastic, great job. They could be spiraling, so you wanna let them know. And it's often the family members will know that they're going into mania before the patient themselves will know. So bipolar 1 disorder, chronic multisystemic cyclic disorder, which means they go from mania to depression. You wanna keep them stabilized on their medication. They can live a perfectly normal life on their meds. Earlier onset results in more frequent episodes than persons who develop the illness later in life. It's a progressive condition with prodromal, which you know what that is, symptomatic and residual states. It can be arrested with an early diagnosis. And what does that mean? That you
Be
can
stopped.
just take care of it. Proper treatment, individually tailored management. And an early onset and a family history of the illness are associated with multiple episodes of continuous symptoms. Symptoms of the illness can be unpredictable and variable. You will not be able to predict how this person is going to act. So let's talk about bipolar 1 again. It can lead to severe functional impairment, alienation from friends. You have a party, you're having this beautiful wedding, everybody's at the wedding. Family member or friend who suffers from bipolar disorder comes in off their meds and starts physically fighting with people, destroys the whole wedding. Can you picture that being alienating? Alienating from family, friends, co-workers. Think of at a job. Indebtedness, if they just spend, what if they, it was so sad, one student shared, she wrote a beautiful paper. You used to have to do 2 papers, AA and another one. So she wrote the most beautiful paper, and actually, I asked her to submit it as an honors, and she won. Her dad had bipolar disorder, he had passed away. But she shared how he used to beat them, the wife and the kids, when he became man. I mean, she said it was awful. And she said that wasn't him. That was not the man that she knew when he was on his medication. She said he would drink excessively. And it was a very emotional class when she spoke. And she said when he was on his meds, he was perfectly fine. But to know something about bipolar, a lot of famous people suffer from bipolar. A lot of famous musicians and actors, and what famous painter had bipolar disorder that you know? Yeah. Oh, Van Gogh, what did he do?
Cut off his ear.
He cut off his ear during the bipolar manic episode. So if you talk, I have spoken to some patients, and what they've said, now, we talk about compliance with meds, how important it is, adherence, that you take your medication. When you listen to a patient with bipolar, I remember speaking both men and women saying, you have no idea how amazing this feels. although, you know, none of us may be able to feel that personally, you can almost understand how somebody would want to feel that way, and then they said, and then they get to the point of no return when you can't have it. I'm feeling really great, but then I start doing things that I can't control. And that's part of the disorder, but sometimes very creative, and then they have to start from square one. Job loss, divorce, incarceration, presence of mood lability and rapid cycling, bipolar 1, that means having many episodes, diagnosis reliant on the occurrence of at least one manic episode or mixed episode and a depressive episode. So in order to get the diagnosis, you have to have both mania and depression. So children and adolescents, depression usually occurs first in children, and then it gets marked by intense rage. The symptoms reflect the developmental level of the child. And all that means, if the child is 10, they're gonna act like a 10-year-old would act if they're 15. Older adults, greater neurological abnormalities and cognitive disturbances. The good thing is the incidence of mania decreases with age. So when you see the lifetime prevalence, 1 to 4%, that's a lot of people. So symptoms onset, usually between 14 and 21, fewer cases after age 40. There is no gender differences. Female patients are at a greater risk of depression and rapid cycling than male patients going from depression to mania. Male patients at a greater risk for manic episode. Comorbid conditions, anxiety disorder they may have, is panic disorder, social phobia, and substance use. And you can almost imagine the substance use. If you're going to experience mania, you'll go out, you'll take drugs, you'll drink, you'll do anything, because it's things that you're not used to doing. Chronobiological theories, that is the sleep patterns and circadian rhythm. Like I said, you don't want them doing shift work. Notify your provider if even there's an hour difference in sleep. It's highly hereditable. We know that monozygote twins show a risk between 40 and 70% of acquiring if an identical twin has the disorder. So that's huge, isn't it? Chronic stress, inflammation, you don't have to need rekindling. Psychological and social theories, you want to focus on reducing environmental stress and trauma in genetically vulnerable individuals. It is not generally accepted that environmental conditions contribute to the timing of an episode rather than the cause. So what they used to say, just like psychosis years ago, and I'm sorry to say it's true today, so we know with major depressive disorder, with depression, we talked about the medications, right? Medications alone do not work with depression. You need to have talk therapy. You can't just give someone a pill and think they're going to get better. They will not get better without talk therapy. With schizophrenia, psychotic disorders, and bipolar, it used to be, and those of you who work in mental health or know of family members, it's a little bit heartbreaking because what they have something called med checks, where you'll come every 30 days, every month, and you'll spend less than 15 minutes with the provider. Oh, how's everything going, no symptoms? And that's heartbreaking because mental health therapy is very costly. And a lot of people want to pick their provider, may or may not be covered. Anyway, with bipolar and schizophrenia, psychotic disorders, they're saying, in the past they used to say just write the prescription, and now they're saying no. People need to talk, so much so that a provider will be able to see that someone is maybe becoming unwell. That's what it's good about talk therapy. So teamwork and collaboration, you want to work toward recovery the goals of treatment, minimize and prevent either the manic or depressive episodes. You know, once they're admitted, they can get back to the blood levels pretty quickly and then be discharged at home. You want to help them, can we avoid stress? No one could ever avoid it. We can manage stress, medication adherence, and maintain social rhythms. Help the patient and family learn about the disorder and manage it throughout their lifetime. So the primary treatment modalities, medication, psychotherapy, education, and support to help the family understand they do not want to be acting in this manner. So let's say you're in a relationship and then you get into a long-term relationship with someone and you don't know that they have this disorder. You know, as the family, you can be a huge support system to this person. But the way they act, it often destroys the relationship because it becomes so disruptive. So priority issues, number one is safety. They have a high risk of suicide. They have a high risk of injury. They have a poor judgment and impulsivity. So much so, when you're on the unit, and let's say I'm walking very quickly and I cut my arm on like a part of the furniture and my arm is bleeding, am I gonna stop and say to the nurse, oh, I cut myself? No, they're gonna keep going, moving very quickly. They'll be pacing up and down all the time. So, Richard, what do you think of this? Excellent. Good job. So mental health nursing assessment, so physical health. They'll have changes in activity, eating, and sleeping. You think they're gonna eat? They're not gonna eat, they're not gonna drink, so they can become dehydrated. They're not gonna eat, drink, or sleep. Diet and body weight, they may lose weight, lose fluids. You wanna do thyroid function test on them. Changes in sexual practice may become very promiscuous. And you wanna see if they have previously used antidepressants. So if someone is undiagnosed, and they have an undiagnosed bipolar, what would happen if they're prescribed antidepressants? They might become that.
Very good.
And that's when you have to discontinue the stabilizers. So mental health appearance. When a patient, you have a question, Richard?
What did you say? What was that?
What did I say?
What was the answer to the question?
Your question?
Your question.
This is Van Gogh.
So if you have someone who's undiagnosed
Here.
yet, and they have bipolar, right?
There's
And a
the
healthcare
Van Gogh.
provider
No, I know.
prescribed them an antidepressant. What could happen? Antidepressant given to a patient who
Depression.
has an undiagnosed bipolar 1, they could become that. So then you don't wanna keep them on that medication. You don't wanna keep them on an antidepressant, you wanna put them on a mood stabilizer. Got it? Okay. So, what's their appearance going to be? Interestingly enough, all right, I'm gonna let you tell me, how do you think in a manic state, someone is going to dress?
Vulgar,
Very promiscuous?
promiscuous, vulgar,
Different,
like revealing.
Exactly, so when I taught med-surg, I taught 22, and when, you go in the morning to get the patients to the unit, and, I had a good relationship with the nurses, and it was their telemetry, and they said to me, they looked very frazzled, I said, what's going on? They said, well, we have a patient on the cardiac monitor who has cardiac issues, but she has bipolar and she's manic right now. I said, do you want me to take her? And they're like, please, please. I said, all right, I'll do it. So I get down, got the students, came up to the floor. I asked one of the students, I asked whoever wanted to volunteer. volunteered. We went, well, she wasn't in the room. She was parading up and down the hall. She had her hair all teased up. She had a see-through,
What is it?
like a negligee, and she had the
Oh.
lipstick, and the staff was like trying to run after her with a gown to cover her. She had high heels on. Someone brought her these things, so we put the gown on her and stayed with her. It turned out that more than one student we had to, it took a great deal of the day to, we walked with her, but we covered her up. But the pressured speech and very impulsive. So that's how they may present themselves. Very acting and dressing in a way that they never would have usually. Very flamboyant. Social network and support systems, you only need one friend really, if you just have one person. And, I think bipolar is actually more socially acceptable, because remember a lot of stars had it, and it was like, there was no real stigma in having bipolar, but more so with a psychotic disorder. Risk assessment, social and occupational functioning, they may have lost their job or have difficulty keeping a job. And their quality of life, when they're on their meds, should be perfectly fine, and you wanna look for the strengths. So therapeutic relationship, it is both interesting and interesting. These are patients that require a lot of emotional care, a lot of refocusing. Come on, let's go do some painting, let's do some art. You wanna remain calm, you wanna avoid power struggles. You definitely do not wanna use confrontation. You wanna respect their personal space, don't get too close. You wanna meet the client where they are. If they're very agitated, you wanna try to what?
Calm them down.
De-escalate.
De-escalate.
De-escalate. And that's vital to prevent relapse. Recovery and wellness, they have periods of stable mental health. And they're usually perfect times to focus on stress reduction and let them know, we know none of us could avoid stress in our life, it's impossible. But we could make sure we go to our appointments, if you can do a psychologist every week, or some kind of mental health, or you could do workshops, you could go to support groups. They found that patients with, who have bipolar disorder do well with support groups because you talk about life-minded situations, situations that they had, illness management and relapse prevention. Physical care, they need rest, they need adequate hydration and nutrition. You want to reestablish physical well-being, and they do have wellness challenges. So medications. Rapid control of symptoms and prevention of future episodes, or at least reduction in their severity and frequency. So what we call the gold standard treatment is the medication lithium carbonate. It's known as the gold standard. It's a great medication. It's not expensive. So in terms of educating the person, it's a salt, so they need to maintain an adequate sodium diet, not restrict their sodium.
Even though this is a sodium, it's a salt?
Yeah, because what we found is the patient, if they become dehydrated, their lithium level will rise. And they could develop something called lithium toxicity, which I'll get into in more detail. So you don't want, if they're showing signs and symptoms of lithium toxicity, you want to discontinue the medication. You don't give it.
So they need more sodium?
Right, that's why I want to say, why do they need more sodium?
Well, they'll need a regular sodium diet. They don't need less sodium. They're not restricted.
Did I understand it right? Because I feel like I understood it as if their sodium intake is too low, then that's, the lithium goes high and vice versa.
Right, well, so we'll get into that, the lithium levels, because you need to stop it and give them fluids to drink. Another thing is activity. So let's say the marathon was a few weeks ago. Can you tell someone with bipolar disorder that they can't run a marathon or those
No.
words? No. But what you have to let them know is when they're perspiring, they need to replenish their fluids. They have those camelbacks, those strap-on, looks like a backpack with water in it and the tubing, and they can drink it. They could do basketball. They could do anything as long as they maintain their fluids. When they become dehydrated, their lithium level goes up. Another, we'll come back to lithium. Divalproic sodium. Did you ever hear of that medication? What's that for? Seizures, right. Carbazepine, lamotrigine, and also at times antipsychotics. So administering the medications, you want to assess for side effects. Compliance, what's that? Adherence, promoting adherence to the medication and teaching the patient, very important. Okay, what do you think, Dimitri, would be the right answer for this?
Lithium?
Lithium is the gold standard, excellent. It works in many patients. Another treatment is electroconvulsive therapy or transcranial magnetic stimulation. I've never seen it used for bipolar, but it can be. Psychosocial intervention, therapeutic interaction. You want to enhance cognitive and behavioral functioning. Cognitive behavioral therapy is beneficial. Individual, interpersonal therapy, adjunct therapy, psychoeducation, teaching strategies, wellness strategies, social skills training. If they get diagnosed very young, they may need social as well as occupational skills training. The family needs to be educated. The family needs to understand they are not doing this on purpose. Implementing milieu therapy, that's a therapeutic, cohesive group. Support groups have been found to be very helpful in developing recovery-oriented rehabilitation. Emergency care, if necessary, the person can be admitted to an inpatient unit, and also intensive outpatient programs, community care, and virtual mental health. Do you think if you're a therapist is speaking with someone that they know on a relationship, that they will know if they're spiraling to mania? Do you think they'll know? They'll know. And this is why you want them to, we'll get into more detail when I do the meds, when you see how I do the meds, I'm gonna ask. Okay. What is the answer to this? Carl?
Oh, yeah,
Yes, excellent, true, good.
that's the first thing to do.
So bipolar 2, they're primarily depressed with brief periods of elevated or irritable moods. So they're not gonna have the mania. The hypomania, it's a mild form of mania, and that's characteristic of bipolar 2. Cyclothymic disorder, less severe hypomania, alternating with numerous periods of depression. So what can trigger these situations? Drug use, prescription medication, and some medical conditions. Okay.
So by reading this definition, so there's a little difference between bipolar 2 and cyclothymic
That's it.
disorder?
I'm sorry?
Is there a little difference between
Yeah,
bipolar?
they're different. They're
Okay,
different.
all right.
So I'm not gonna
You don't have to
ask
do
too
it.
much about that. So I'm going to put up medications. That was 12, right? So that was in unit 3. can take a break, and then